Angie Walker, DeQueen, Arkansas. I graduated residency from the AHEC, the Area Health Education, from Southeast Arkansas in El Dorado. It's based in El Dorado, Arkansas, in 2003. And we essentially came to DeQueen and started from scratch. We built a new house, a new clinic, and started practice from there. And really, I really didn't have any question or really never considered having paper records. Even at that time, you could see that the medical record, as far as the part that was, that the medical record was becoming central to both getting paid and from a regulatory point of view. And that's the one thing that electronic medical records do better than anything else, is they can accomplish a redundant task. And they also save space as far as not having to have a place to store paper records. Electronic medical records, since we had them from the beginning, have allowed us to avoid having to have storage. So as the documentation becomes more important from both a regulatory and a patient care point of view, the thing that medical records allow you to do, electronic medical records, is to deal with that redundancy and documentation very well. And it makes it very efficient to document what you've done, to both get paid for it and, God forbid, in an audit to prove that you actually did that. When we first started practice in 2003, I had the opportunity during residency to work both with paper records and with electronic medical records system. One thing that I found is about 85 to 95% of everything in that documentation that has to do with a given illness is the same. It's redundant. And that's how we designed our electronic medical record system to work. And if you can consider for a moment, a patient comes in with if you take 100 patients that come in with sinusitis, 85 to 95% of the things that are documented in that acute care visit are going to be identical. And electronic medical records allows you to deal with that very efficiently. So you just go in and put the things that are specific for that visit, that are different, that are unusual. Right, we thought, well, we're already pretty much compliant with everything. We might as well get involved in this program and get credit for it. Yeah, patients often, will ask, how's my information being protected? Can someone hack into that? And my answer always is, there's always a possibility, but there are many, many safeguards in place to prevent that, especially with electronic medical records.
What system do y'all use?
We use the Welford electronic medical record system, and it's tied to a DEMIS for billing. And in my simplistic view of it, the medical record system is able to talk to the billing system in order to make a smooth transfer of the billing process from the office visit to the front desk as the patient is leaving. One thing that I like to use a lot is the graphing capability of our system. So we've all had to deal with INRs, and they go up and down. But it really brings that that patient's condition into clarity when you can see that on a graph, and you can see if the overall trend is up or down, and that really allows you to make real precise dosage adjustments on the Coumadin. And you see the same thing with diabetics and hemoglobin A1Cs, and the same thing with hypertensive patients. You can graph the systolic blood pressures and the diastolic blood pressures, And you can tell what the diastolic blood pressures are doing over time and what the systolic blood pressures are doing over time. And that really aids in being able to decide what's the most appropriate treatment for those patients. Whether you need a calcium channel blocker, a diuretic, a beta blocker, etc. One of the biggest concerns is just the cost of implementing it. And one cost that I think kind of gets less press than it really should is the cost of converting those old paper records into computer records. Because for the first 2 or 3 years, you're still having to maintain paper records while you're getting that data transferred into your electronic medical record system. And then I hear many concerns from doctors about HIPAA and the same security type issues that we all worry about. Another concern too is that doctors are concerned that they will spend an inordinate amount of time dealing with their medical record system rather than face-to-face conversation with the patients. And that concern, I think, gets less and less important as time goes on because there's excellent voice recognition software now. It's fairly easy to type. And you can modify your medical record system to work with whatever means you like to transfer data into the system. No, I think it's pretty easy. I hope in the end what we see is a common language and a common database so that my medical record system can log into some common database and all of that information will be immediately uploaded into a patient's chart. And we're not there yet, and I think we still have a ways to go. But I think we're working in the right direction with that as our end goal. I would advise them all to go ahead and take the leap, to get familiar with the medical record system, try to implement it. It just, as time goes on, as regulatory burdens, as bureaucratic burdens from Medicare, Medicaid, and other third-party payers get more and more onerous, you're just going to have to be able to deal with a vast amount of data much more efficiently than you can ever hope to do with pencil and paper.
I think it's given us better access as far as what our patient population is. It's at our fingertips that we can pull the demographics for our office. We know how many hypertensive patients we have. We know how many diabetic patients we have. We know how many of those patients are female, how many are Hispanic. And it makes it easier as far as the services that we need to provide, as far as even just minute things like ordering patient education. We know who our customer is, so to say. We know what we're dealing with in our area. We know the battles that we have. We know where to, point our efforts. On my side, I have not heard any concerns. It's actually made to me the process a lot easier. Patients can request their medical records and we can print them immediately or at least give them access to them within 48 hours. And that makes it really nice when they're going on to see a specialist physician or what have you. They know they can walk in and within just a few minutes we've got that ready for them. It's just, they have access, once they leave our office, they're provided with a visit summary for that day. And it tells them, this is what I came in here for today. These are the medications that I'm on. These are the changes that he made. These are the labs that were done. So it kind of gives them an insight to their record. Whereas with a paper chart, I don't know that you would be able to get that much access to it. I don't think that we would be as successful if we had paper charts. It would just require of course, more room, more space. You're looking at an extra couple of employees who are going to be pulling those charts, making copies, and handling those charts. And then, of course, once they reach a certain age, you have to move them out and you have to maintain them for 10 years. And I cannot imagine that part of it. The other thing that I really like about our EMR is that we have reminders that pop up for our patients. If you walk into our office and you're a female over the age of 50 and you have diabetes, he's going to be getting constant reminders that say, hey, have you looked at her A1C? Hey, has she had a colonoscopy? So it takes some of not necessarily the burden, but the responsibility off of the physician. If you're in here for a cough or a cold, he's not going to be thinking colonoscopy and A1C and stuff like that. Whereas to me, it provides better management of the disease. You may be in here for a cold and flu, not anything to do with your diabetes, but that's still there. And the EMR is still kind of chipping away at it and reminding them of those services. We have a quarterly office managers meeting, and we've spoke about it at length there because I know we have some local physicians who've not made a decision at this point. We also have a couple of physicians who are on EMR, which makes it really nice. Because if you're out and you have a patient that's going to be seen by the other physician, it makes it easier to get that data back and forth so that patient's not kind of in limbo. We've just kind of discussed it. We've opened our office. There's been a few of the physicians in town that have come through and then looked at our system, and I think maybe it's kind of helped them understand what it is, and maybe help them make decisions about what they would like in theirs. Not necessarily that they would buy the same system, just kind of, lets them know, hey, this is what's available, this is what I can request, this is what I cannot request. Yeah. Randy had moonlighted in several different places, so he knew he had moonlighted in offices that had and in hospitals. He'd moonlighted in the hospitals, but he'd also, in residency, you have to go spend a month at different offices. So he had seen paper charts versus an EMR. So it just kind of instilled in his mind at that point that he wanted an EMR. We then had a medical practice consultant that we sat down with and explained to them what we wanted to do, and he came up with several different alternatives. And we were able to try those programs out. And then within 6 months to the end of residency, we picked out the program that we wanted along with the billing program, and then we spent those 6 months learning how to use that software and designing it how, he wanted it to be set up. Now, that's not to say that we make changes every day, like with the new wellness benefit. We've been up here today working on a wellness benefit form and things like that. So I think it's ever evolving, ever expanding. But the good thing is that it expands with you. Our EMR will do as little as we want it to do, or it will do astronomical things that, you just wouldn't think about it doing. Two of the things that we've been working on the last year is we're also participating in the Arkansas Chronic Illness Collaborative. And we're actually doing two different collaboratives. We're doing the diabetic side and we're doing the hypertension side. So we've set up rule reminders for those patients as far as A1Cs, hemoglobin, and then Chem 12s and things like that for them to get those procedures. We also sat down and Dr. Walker came up with his standing order list, so we've been able to insert that in there to remind the nurses of things that need to be done. Again, this way it kind of alleviates some of the burden off of him, and it makes everyone responsible for that patient's care. We do a visit summary when that patient leaves. They know everything that's going on with them that day. We do med reconciliations every time the patient comes into the office, especially if they've been discharged from a hospital or a specialist. We are maybe going to do some reminder letters. I haven't made my mind up about that yet, but I'm kind of working on that. But we've also done, we've kind of revamped our whole office visit template. to include different information that he now wants to see. We do brochures. Now when that patient comes in and there are brochures that he wants them to specifically have, he sits down and he creates his own brochure. So if that patient happens to come in and want to be talking about diet and exercise and stuff like that, he has stuff that he specifically created himself. And then also within our EMR, it has brochures for every disease, medicine, and what have you, so that he can print that, at his fingertip as well. I see it going more to maybe more of a managing chronic disease, or leaving the managing of chronic disease or slapping a Band-Aid on it is kind of like what I like to call it, and more into a preventative, so that, like I said, if that patient walks in and they have a cold or a flu and they're diabetic, you're not just dealing with the cold and flu and then in 2 weeks they have to come back because their A1C is out of the roof. You're dealing with that patient as a whole versus the issue that they're here for today.